Good morning, everybody. So my brief is to talk about the multi-drug resistant keratitis today. So I'll start with this case. This is a 57-year-old lady who came to us way back in 2011, and this was how the cornea looked like in the beginning and after the uneventful PK which I did for this. This ultimately turned out to be primary amyloidosis. So this patient was, or this case was very dear to me. However, about 7 months later, the patient came to us in a routine post-op visit, and we just did for astigmatism, we just removed a suture from the steep axis, and a week later she came up with this. I was very distraught. Most probably this was a nosocomial infection, probably a hospital-induced. So this was involved the peripheral cornea as well as the sclera. We did a scraping as well as a scleral deroofing, and the microbiology, as you can see, showed Pseudomonas aeruginosa, which were resistant to everything except colistin, and there was an intermediate sensitivity to imipenem also. I really tried very hard to save this eye, first on medical treatment on colistin drops, and ultimately did a scleral patch graft. You can see the scleral patch graft is much broader than the cornea itself, but ultimately could not save the eye, in the sense that we could salvage the eye but not the vision. This is another patient which we did just about a year ago in December 2014. Patient had a very good pseudophakic vision in the right eye, 20 by 20 vision, and however in the left eye had a pseudophakic bullous keratopathy. He went uneventful D6 surgery on 28th of Feb 2015, just about a year ago. The donor was an 18-year-old male who had died in an accident, was on a ventilator, excellent cell count, and I thought this graft would do very well. The next day, which happened to be a Sunday, I will never forget this particular Sunday. So the graft was very well opposed, the lenticule, but the patient was vomiting, had a severe pain. The vision was PL plus PR accurate. The IOP was very high. First I thought probably it's just air in the anterior chamber which is causing the high pressures, but there was a graft edema and there was a cellular infiltration around the lenticule. So we suspected graft infection, and I had endophthalmitis at the back of my mind, so got a B scan done the same day around 3-4 hours later, and we could see some echoes in the vitreous. So we made a diagnosis of a post-DSEC acute endophthalmitis, and immediately the same day, around afternoon, around 3 o'clock, the patient was taken up for removal of the DSEC lenticule, and a PK was done along with a pars plana vitrectomy, and intraocular antibiotic was given. We gave vancomycin and ceftazidime for this patient intravitreally. The next day, more or less, patient was slightly better, but there was no significant improvement. Just because it was a very short duration of onset, in the sense I had done the surgery on Saturday around 6 o'clock, and 9 o'clock Sunday we had so much of a extensive infection. I was thinking about probably it's a it was reported that it's a gram-negative bacilli on smears. So I was wondering if it is a multi-drug resistant Pseudomonas. So we started the patient empirically without having the sensitivity on topical colistin eye drops. And also the same day, we repeated the intravitreal imipenem, again considering that this probably would be multi-drug resistant. So on 3rd of March, we got the culture sensitivity again. As you can see, this was resistant to all except colistin, and this was reported to be Klebsiella, which is a gram-negative bacilli. We had subjected the donor rim, corneascular rim, also the mate cornea, the contralateral eye, which was not used for the culture sensitivity, and everything grew Klebsiella. So the source of infection was the donor cornea in this particular case. We have, there is no much report about the use of colistin in the eye. There are one isolated case report so far, the use of colistin in endophthalmitis, which is from Mumbai, from Hinduja Hospital. And we have also published one case report about colistin, use of colistin in keratitis. So we started this patient on both IV colistin, topical colistin eye drops, and intravitreal colistin was given on 4th and 7th of March. Patient gradually, the vision, the endophthalmitis subsided. The cornea on the surprisingly did very well because we have did the PK on the first post-op day itself. However, it took about 5 months for this patient to stabilize. It took about 5 intravitreal injections of colistin. Patient had a recurrent episode about 4 times, and ultimately we took out the nucleus as well as the capsular bag and had to do a pars plana vitrectomy with silicone injection, and that's how it settled ultimately. These are some cases which we have been saying over the past 3-4 years, multi-drug resistant. Generally, it's a gram-negative bacilli which we see. The first case was about Pseudomonas, the second was Klebsiella. As far as the definition is concerned, the multi-drug resistance is defined as where the bugs are not sensitive to at least one agent in 3 classes of antibacterial agents. Then you have what we call extensively drug resistant bacteria, which are not sensitive to all but 2 of the antibacterial classes of antimicrobials, and pan-drug resistances which are not sensitive to any of the antibacterials. So resistance, as we know, is emerging problem which we feel we face not just in the cornea but also in the systemic illnesses, and we are all aware of the fluorocon resistance which is increasing. This is the LVPI data which we collected from 2011 to June 2013, and as you can see, this comes from all keratoplasty, ocular surface diseases, trauma and others. Out of these 193, 173 were able to heal on medical treatment, 20 needed surgical management, and out of these 193 you can see all the 193 were susceptible to colistin, 113 were susceptible to imipenem, and you can see here there was a great resistance to most of other antibacterials such as ofloxacin, ciprofloxacin, moxifloxacin and also gefloxacin. So we had a spurt of these cases in 2011 and 12. Luckily, this kind of a spurt is decreasing now, and these were not just the hospital-acquired infections. We have seen a significant number of community-based infectious keratitis also, which has been because of multi-drug resistant Pseudomonas. This is just a chart which shows how the resistance has been increasing over the years. This is a specific case report of about 22 eyes which had a clear corneal tunnel infection following uneventful phacosurgeon. This was reported from outside our institute, and all these cases were referred to us. These 2 slides are courtesy Praveen Krishna because he handled these cases. So all of these patients had an infection because of Burkholderia, which is related to Pseudomonas, and all these were susceptible only to colistin. So 22 of these patients, all 22 needed patch grafts or penetrating keratoplasty. So as far as the management options are concerned for these cases, first and recognize the existence of this kind of a scenario. You have to deal with the prevention also. If you people have been following news, just about day before yesterday, Union Health Minister Nadda has launched a scheme whereby all the antibacterial, the systemic antibacterials, will have a red line on the strips so that you know that these are antibiotics and should not be used unless really necessary. You also need to understand that mainly the resistance comes not from just the human use of antibiotics, but also these in the veterinary use is much more than the systemic use where this resistance generally develops. Talking about the colistin or the medications which we are using these days for multi-drug resistant pseudomonas or gram-negative bacilli. So colistin was used way back in 1960. It was routinely being used from gram-negative bacilli. However, this use was discontinued because it was considered to have a significant nephrotoxicity. However, now we are rediscovering the use for ophthalmic use. So this is a case report which was published way back in archives in 1960, and this is a case report which we have published last year in Cornea about the use of topical colistin. We are using xylistine, which is available from Cipla. So this comes in 1 million units. So we take 1 ml in 10 ml of distilled water, and this 1 ml of this solution is mixed with 3 ml of distilled water. This gives you a percentage of 0.19. Allow me to say that there is no particular studies which have been used where we know that what is the exact concentration. The publication which I mentioned of 1960, they have used 0.12%. We are using 0.19. The publication from Hinduja Hospital, they have used 1% colistin. So as of now, this is just based on few case reports. We have also used imipenem in certain cases for gram-positive bacilli which are resistant to moxifloxacin or getafloxacin. We have used vancomycin, of course. To conclude, we know that getafloxacin and moxifloxacin are very good antibiotics, but they should be used very judicially. Vancomycin still remain the drug of choice for gram-positive bacilli which are resistant to other bacteria. We see an increasing trend of multi-drug resistant pseudomonas, which is generally sensitive only to colistin and imipenem, and we need to look for this particular group of diseases or keratitis. Early surgical intervention in these cases is very, very important. Thank you for your patient listening. I would be happy to answer any questions.